Now, whilst the lockdown is underway, South Africa is also doing other things to flatten the curve or reduce the rise in the number of cases of COVID-19. How effectively people infected with the virus can be detected and isolated will, of course, affect the numbers. Testing, contact tracing, isolating people, all parts of the strategy. To discuss all of this and should work and how it could and should work in practice, we're joined by the head of the Centre for Vaccines and Immunology at the National Institute for Communicable Diseases, Dr. Melinda Suchard. Doctor, thank you very much for joining us. It's not just lockdown that's happening. How active would you say we are in chasing down this virus, in finding the people who are sick and isolating them at the moment?
Hi, good evening. South Africa has been very active at isolating and tracking down cases of COVID-19. Cases themselves are being quarantined, and any of their contacts are being actively investigated with testing, swabbing, and there's active contact tracing to work out if any of their contacts are infected.
How effective is that contact tracing? We know that, for example, officials can now use cell phones and find out who people have been near, but how is it working in practice?
In practice, I think we are still using contact lists. The cell phone technology is going to be implemented. I'm not sure if it is already running or only about to start, but it's in the pipeline. And contacts are being actively, there are Department of Health officials who are visiting the houses of contact to actively screen them.
When, say, the lockdown ends, I mean, you're trying to trace people who've gotten onto several public transport facilities, for example, mixing with lots of people. Could it become a tsunami when you're doing that across the country? Is it, in fact, doable? It is doable, but
it is doable only in the stages where there is no tsunami. So it's very effective in the early stages of transmission, and that's why it has been effective up until now in the country. And as we see more cases, it might be limited to places where there are fewer cases. So it's important for us to get a sense of the geographic spread of the virus so that we know which areas, for example, are having their first case. Because one can intervene very successfully in the first case in a particular geographical area, whereas if there are hundreds of cases, then trying to track down all the contacts becomes less effective.
Yeah.
So as we become more precise and as we receive more information from the community testing and screening, it will be able to help us to narrow with more precision the areas to target. But at the moment, throughout the country, all the contacts are being actively investigated.
Okay, so if we look at the different prongs, testing a big part of this. If we look at testing, it's being done in the private sector and the public sector. The National Health Laboratory Service said earlier it had kits to do 15,000 tests a day. But we've got the latest figures from the Health Minister tonight, about 90,000 tests. That's not 15,000 a day. Surely we can up the ante there.
Yes, so the testing platforms are changing. There is a new test for which we are waiting. It's just been approved and we are waiting for the kits. That's the Gene Expert test. So as the new kits become ready for use, so the capacity in the country expands because many of our laboratories already have that particular instrument for testing. So the capacity for testing is being broadened each day.
So tell us how that changes the testing outcomes, that new test.
That new test will allow many more public labs, the NHLS laboratories, to also be able to test, whereas at the moment it's mainly the large virology laboratories attached to public hospitals that are conducting the testing. There are peripheral testing sites in clinics and mobile laboratories, but most of the tests are being done at the academic virology laboratories in the public sector. But with the new test becoming available, it will allow decentralized testing by the public laboratories.
Would you say we're mass testing right now, or are we still getting to that phase?
We're mass screening. So the mass screening has started. That is when health workers are going door to door in targeted areas to ask people in the homes if they have got symptoms, if they have fever, if they have coughing, But in that way, they are screening households for any potential COVID-19 cases, and then they will refer those cases that they find for testing. In some cases, they will bring the nurses to do the test with them in those testing teams. So the screening has started. We don't have many of the results yet from the screening. It's really just been going on for about a week or so, and we are waiting for the outcome of that active screening. So that's really going out and looking for the cases rather than waiting for them to go to clinics to be tested themselves.
Doctor, for people who are watching this very frustrated with the lockdown, can you explain why this is also important, these strategies, and also just not mingling, flattening the curve? Can you remind us?
It's absolutely essential to flatten the curve. If you think the population in the country is approximately 60 million people, if we estimate that half of those people may catch this virus if we didn't contain it and if we didn't flatten the curve, that would be 30 million people. And we know that about 5% of all the people who catch the virus need ICU intensive care. That works out as a figure of 1.5 million people. And I think our ICU capacities in the country is around 5,000 or so. So we cannot have 1.5 million people needing ICU at the same time.
Yeah, that's an incredible figure.
Yes.
And people are saying we should not do this distinction anymore. Well, we shouldn't refer to it as a very bad flu. It's very different. The way it spreads, very different. Just look at those differences for us.
So it has some similarities with the flu in that they are both respiratory viruses and spread by respiratory droplets. There are some circumstances in which the COVID-19 might also have airborne spread, for example, in healthcare settings when there is invasive procedures being done. However, I think the main differences between the two viruses is that the death rate from COVID-19 is higher. The estimates are around somewhere between 1% and 3% of patients who get COVID-19 die, whereas for influenza, it's only about 0.1% of patients who get influenza die. And that really is one of the major differences.
All right. Thank you very much for your time this evening. That was the head of the Center for Vaccines and Immunology at the National Institute for Communicable Diseases, Dr. Melinda